Heisseger syndrome, or J-wave syndrome, was once thought to be a completely benign finding on an ECG. How did we learn that it's actually strongly linked to sudden cardiac death? That's a dramatic shift in understanding.
It's a perfect example of how medical knowledge evolves. J-wave abnormalities were first reported way back in 1938 in a hypothermic patient. For many decades, early repolarization patterns, which include the J-wave, were indeed considered benign, no clinical concern. However, a dramatic shift occurred in 2008 when independent research teams from France and Israel both published landmark studies. They conclusively demonstrated a strong correlation between these early repolarization patterns, particularly prominent J-waves, and rhythmogenicity, directly linking them to idiopathic ventricular fibrillation and sudden cardiac death.
Wow.
This completely revolutionized how we view these seemingly innocent ECG findings. They moved from being a curiosity to a red flag.
What's behind these mysterious J-waves? What are the current theories explaining their origin and their surprising link to such severe arrhythmias?
The primary theory attributes J-waves to a genetic loss or gain of function in ion channels, similar to what we see in Brugada and Osborne syndromes. This mutation leads to an electrical gradient between the epicardium and endocardium, causing earlier repolarization in certain areas. This electrical imbalance can create a substrate for re-entrant arrhythmias, making the heart susceptible to dangerous electrical storms. Some less supported theories propose late depolarization from delayed activation, but the early repolarization hypothesis is more strongly supported, especially because the J-wave decreases with tachycardia.
Who is typically affected by Heisseger syndrome, and what are the clinical manifestations?
It commonly affects young males, especially athletes or very active individuals, and there's a notable prevalence in those of African American origin. However, as individuals age, the male predominance tends to decrease. Patients typically present with symptoms that are gravely serious: unexplained syncope, episodes of polymorphic ventricular tachycardia, and idiopathic ventricular fibrillation. In some cases, they may have a history of resuscitated cardiac arrest or a clear family history of sudden cardiac death.
Are there different types of J-waves, and how do we identify them on the ECG and through further testing?
Yes, there are three distinct types based on their location and morphology. Type 1 J-waves are common in young athletes, typically in leads 1, V4, V6, and generally follow a more benign course. Type 2 J-waves are in leads 2, 3, AVF, and are associated with moderate risk. Type 3 J-waves are the most concerning, seen diffusely in many leads and highly associated with malignant arrhythmias. To identify malignant patterns, a provocation test with adrenaline or a stress test can be used, as benign forms often disappear during these tests. A 24-hour Holter is suggested for unexplained VFib, alongside echo, MRI, angiography, and biopsy to rule out other causes.
What are the formal diagnostic criteria for Heisseger syndrome? How do doctors formally confirm this?
The formal criteria were set by consensus. First, diagnosis is confirmed by a J-point elevation 1 millimeter in 2 or more contiguous inferior and/or lateral leads in a person with a history of resuscitated unexplained VFib or polymorphic VT. Second, it can be diagnosed in a deceased patient with sudden cardiac death, no structural heart defects on autopsy, and a previous ECG showing that J-point elevation. Third, simply the presence of J-point elevation 1 millimeter in 2 contiguous inferior and/or lateral leads on ECG alone can also confirm it, especially if clinical suspicion is high.
How is this serious condition managed, and what's the prognosis?
For patients whose J-waves are only in precordial leads, the risk is considered very low, with excellent prognosis. However, if the pattern is in the inferior and/or lateral leads, the risk is significantly higher. The magnitude also matters larger ways, higher risk. For symptomatic patients and those with aborted sudden cardiac death, the primary treatment is an implantable cardioverter defibrillator, ICD, to prevent future fatal arrhythmias. Medications like isoproterenol and quinidine may be added to help prevent VFib episodes. Quiet for 2 seconds.
Osborne waves have a unique connection to body temperature. How are they discovered, and what are their other names? Sounds like they've had quite a few aliases.
They certainly have. These distinct waves were first reported by Tomaszewski in 1938 in a patient suffering from hypothermia. However, it was John J. Osborne in 1953 who extensively described and firmly attributed this specific ECG pattern to hypothermia based on his research. They've accumulated many names: KJ or H waves, camel hump sign, late delta wave, hat hook junction. All describe the same characteristic ECG finding that emerges when body temperature drops significantly.
Are the underlying mechanisms for Osborne waves similar to other syndromes we've discussed, like Brugada or Heisseger? Seems like a recurring theme.
Yes, there are definite similarities, indicating a shared electrical vulnerability. Just like Brugada and Heisseger, both early repolarization and late depolarization are suspected. The repolarization hypothesis, more supported, suggests a transmural gradient between epicardium and endocardium is created. This can be triggered not only by hypothermia, but also by ischemia, hypercalcemia, diabetic ketoacidosis, hypothyroidism, sepsis, brain death, even drowning. Some less supported theories involve late depolarization, so while hypothermia is classic, the underlying disturbance mirrors other serious conditions.
Given its broad associations, what should clinicians look for when Osborn waves appear? It sounds like a clue to many different conditions.
Indeed, their presence necessitates a very careful patient history. As they aren't pathognomonic on their own, they're a signpost. They are, of course, common in therapeutic or accidental hypothermia. Beyond temperature, they can be seen in diabetic ketoacidosis, hypothyroidism, sepsis, brain death, Parkinson's disease, certain drug overdoses, drowning. Furthermore, they can appear in ACS, hypercalcemia, Takotsubo, myocarditis, concentric hypertrophy, or even as part of Brugada or Heisigera syndromes. Their presence always prompts further evaluation to find the true underlying cause.
Where do these waves actually appear on the ECG, and how do we differentiate between hypothermic and non-hypothermic causes?
The J point on the ECG is the landmark between the QRS end and ST start. When this J point elevates, creating a hump, that's the J wave or Osborn wave. To differentiate causes on the ECG, look for other clues. Hypothermic patients typically show bradycardia, longer PR, QT, QRS intervals, maybe shivering artifacts. Generally, the colder the patient, the steeper the Osborn waves. Distinguishing from Brugada and Heisigera involves evaluating their specific criteria, as the Osborn wave can be part of those patterns.
So, can the diagnostic criteria for Brugada or Heisigera syndromes be applied when you see Osborn waves? Are they sometimes overlapping?
Yes, exactly. In cases where the Osborn wave is part of the presentation of Brugada or Heisigera syndrome, their respective diagnostic criteria would be used to confirm the specific underlying syndrome, not just Osborn waves in isolation. The clinical context is key.
What's the prognostic value of Osborn waves? Does their presence indicate a better or worse outcome?
The prognostic value in hypothermic patients is actually quite debatable. Some research suggests higher mortality with them, others note worse prognosis in hypothermic patients without them. So it's unclear there. However, when Osborn waves are due to non-hypothermic causes, meaning they reflect a different underlying pathology, the prognosis is generally considered poorer. The severity depends on the ECG leads involved and the wave's magnitude. In these cases, they can be a serious warning sign.